Now, according to the World Health Organization, almost half of all deaths in Ghana are as a result of non-communicable diseases, hypertension, diabetes, stroke, heart attacks, and chronic respiratory diseases. This makes NCDs the scariest, if you like, diseases for anyone living in Ghana. Luckily, though, we have the power to keep it in check or under control, because the biggest source of the problem comes from our poor eating habits, lifestyle, and the biggest one, ignorance. So this afternoon, we've put the experts together as part of the year-long campaign by Joy News, led by our health desk, to help bring NCDs under control. They are with us in the studio and via our virtual platform, Zoom, to first of all, let you know what you are doing wrong and predisposing you to it and what you can do to reverse it. Let's have some facts here. And so for top 10 conditions by volume and cost, we have pregnancy and delivery, hypertension, cardiovascular complications and diabetes, digestive tract, respiratory tract, malaria. We have ear, eye, and oral cavity, muscle, skeletal system. We have others. I mean, anemia, skin, what you can think of. These are the 10 conditions that we put together. 43% of all deaths in Ghana is caused by non-communicable diseases. That's a look at the NCD in Ghana. So that's almost half of the reported deaths in Ghana caused by NCD. And that, for me, is a pandemic. And, I mean, we go on, we have more on this matter. And the source of this is the World Health Organization. And so these are the facts that are available to us. We have leading diseases, heart diseases, stroke, cancer, respiratory diseases, diabetes as well. So these are the top, some of the leading causes, and again, from the World Health Organization. And so this is not something that you can joke with. And highest contributor to multidimensional poverty, that's there you have it, health, living conditions, and of course, education. Without education, even the Bible says that my people perish. So without education, you are living in a no man's land. I mean, you think you are doing the right thing, but you're actually endangering your life. So those are the figures for you. And these are things we take for granted. We are more interested in the diseases with somebody who say the World Bank English. But malaria and the rest. And just a while ago, we were talking about the clearing of goods at the Tema port and the fact that it's taking us 1 year to have them cleared. Even with the public function that came with it, only 14 out of the 185 were cleared, giving indication that in the days to come, we'll have to do more on this. So what are the issues and how do we go around the issues that we have on our hand? Dr. Florence Koyo Akumia is a cardiologist, fellow in training. Dr. Florence, you're welcome.
Thank you.
And of course, Dr. Nana Akusia Kunedu Dakum, family physician. Doctor, you're welcome.
Thank you.
And of course, Christopher Agbega is a patient advocate. Chris, you're welcome.
Thank you very much.
All right, so let me start with you, Dr. Florence. The issues we are discussing, how bad is it?
In terms of, I am in the field of cardiology,
right.
So I'll focus mainly on the cardiovascular diseases, and actually is the leading cause of death globally, and even more so in Africa and other lower and middle income countries. The prevalence has been steadily increasing. Like you said, we used to suffer more from malaria, infectious diseases. But now we're actually plagued by a double burden where we have a high prevalence of these cardiovascular diseases and the infectious diseases, but we have not prioritized care, cardiovascular care in the country yet.
So if you can break it down for us, when you talk about cardiovascular disease, what diseases are we talking about?
So if you break down the word cardiovascular, you're talking about the heart and the blood vessels. So by extension, also organs that are supplied by these blood vessels. So you have stroke falling under cardiovascular disease because it affects the blood vessels. Hypertension is a risk factor for cardiovascular disease, and there are several other risk factors which I'll talk about eventually. But we are talking about strokes, we are talking about heart attacks and blocked blood vessels to the heart. We're talking about what we call heart failure, where the heart is unable to perform its function well. We're talking about blocked vessels to the legs, where people develop wounds that don't heal, and many others.
All right, so let me come to you, your initial comments on this matter. Dr. Nana, what will be your introductory remarks on the matters we are discussing this afternoon?
Like Florence said, the burden of, because she's a cardiologist,
right,
but the burden of non-communicable diseases in general is very high. in Ghana and the world over, and it's highest for people in low and middle income countries. That's Ghana. Don't have money.
You don't know. Of course. We are even struggling to clear containers at the point.
Exactly. So these are conditions that result from quite often unhealthy behaviors and unhealthy exposures. And in a way, you can do things to prevent them. And that's the important thing. You can make certain changes, adopt certain lifestyles that will help you to either prolong the time before you get the condition or prevent you from getting the condition at all. Or if you already have the condition, help you to manage the condition so that you live a full and healthy life that is not restricted. Yes.
We're going to break it down, but let me also bring in Chris. Chris, what's your story?
Thank you so much for having me and also for the panel put together. My story has been 17 years of living with a neurological condition, which is also an NCD. And for me, anytime, as a patient advocate, anytime I'm given the opportunity to speak, I try to broaden the scope for us to understand that there are key stakeholders responsible for the entire NCD prevention, treatment, care, and support space. So normally, yes, you hear lifestyle, it's true, but most of the time, you realize that the regulations that are also needed to ensure that we have safer environments where, as a youth or as a young person, you can strive without having to, fall into some of these things that have suddenly found its way into our environment. That is one of the key things that we need to talk about. For me, I know one of the issues is cost, because it took me 9 years to get my diagnosis from my first symptom. That was from 2007 to 2016. And as early as 2011, 2012, when the doctors finally said, okay, you need to carry out an MRI scan, and there was no money to do that. Then you are now caught up in the loop of you having a condition with no diagnosis. You are now taking medications. You don't know for what reason, but then you are also trying to manage the condition as you go, until I finally got my diagnosis. And so I think that would be my opening statement, for us to understand that when it comes to NCDs, there are multiple stakeholders involved in handling the issue of NCDs.
And the thing that almost half of all deaths recorded in Ghana is from NCDs. Yeah. I don't know who's going to take the question. Why is it so?
I believe it's multifactorial. It's not just one thing. He mentioned a few of the things. It takes so long for people sometimes to even get to know that they have a condition, sometimes through no fault of their own. For instance, he said he started experiencing symptoms and he kept reporting to the clinic, but they weren't able to get him a diagnosis, partly due to a funding issue, okay? But there are some people, you may not even realize that you are having certain symptoms. So you are having those symptoms, but you are not aware that that's a problem. So you keep living your life until one day it gets so bad, it lands you in the hospital and they're like, oh, you have diabetes, oh, you have this problem, oh, you have that problem. Quite often, because we are not screening, we are...
People are not even taking medical tests.
Yes, early detection, yes. So there are some conditions that once you hit a certain age, you should be screening. And then we also have certain belief systems. Our belief systems around Tofiakwa, it can't happen to me.
No, we'll spend our time
exactly.
at the church to pray.
Make donation. Our belief systems are also something that sometimes hamper the diagnosis process. Then when we do have a diagnosis, consistency and maintaining a management plan is sometimes difficult, because taking medication every day is not a simple thing. Again, it comes back to funds. Can you afford the medication?
I mean,
there are so many issues.
The church matters. I think that one can be classified under education.
Oh, some very educated
exactly.
people will still come and tell you that.
I live with somebody who is very close, and she's always listening to the radio. Anytime you hear a medicine, the next thing you see, the person is going under the screen.
Exactly.
And I told her, you sent me to school, so you should start to allow me to educate you on some of this. But she finds confidence in the things she hears on radio rather than going to the hospital and have the matter really checked. But when I also look at the rank, hypertension and the rest topped.
Yes.
Why is it so? And now I'm getting to even read about people in their 20s, early 30s, being exposed to this. Is lifestyle the real issue, or there are more underlying issues that we are not aware of?
Okay. So I'll first speak to the fact about the more than half, or almost half deaths are due to NCDs. Like it was said earlier, NCDs cover a whole spectrum of diseases, respiratory diseases, heart diseases, and the like, neurological diseases and the like. So definitely they will come together to form the bulk of the deaths that occur in the country.
Right.
And why is cardiovascular disease ranking high, is being black is a risk factor for cardiovascular disease.
Being black
is a risk factor for cardiovascular disease. Among other races, which also Asians also have high risk for cardiovascular disease. So that is one risk factor for it. And with our socioeconomic status and educational level, it's also difficult to finally come to a diagnosis. Like she said earlier, oftentimes you don't have symptoms of it. So you usually come with a complication of it. And once complications develop, they are one after the other, and oftentimes it's difficult to control. Now, being black, being hypertensive, usually the hypertension in blacks is more difficult to control.
Why is this so? Is it because of the way we were born?
It's part of our genetic makeup, and we call something salt sensitivity. So we found that the hypertension in blacks is a salt-sensitive hypertension. So that's why one of the major things we hammer on is the salt restriction, or taking less quantities of salt as part of the lifestyle management of hypertension and other cardiovascular diseases. So it's just part of our genetic makeup, and how our hypertension happens, how it comes about. So treating it is different from treating a Caucasian.
Right.
And even when you're on treatment, getting it to target levels is even more difficult than a Caucasian. Yeah. So we are finding now that people are now getting hypertension at a younger age, mostly influenced by lifestyle, because we have been black all along. Mm-hmm. So there has been this westernization, changes in our diet, locomotion, so we don't walk much, we don't exercise much. There's increased stress. So chronic stress has also been found to be a risk factor for cardiovascular disease. So increase in stress, anxiety, depression, all these are on the rise.
Especially when you live in a capital city.
Yes. I mean, you wake up at 5 a.m. to beat traffic.
Right.
You sit, and yet still you sit in traffic. Mm. You get to work, you work, you leave around 4 or 5, sit in another traffic, get home, sort out things at home, go to bed, you would sleep 4 or 5 hours because you have to wake up early, get your kids ready, and it's a vicious cycle. You keep doing that over and over again if you don't intentionally plan for rest. So it's going to be a chronic state of stress, and that will predispose you.
But I don't think, adopting a healthy lifestyle is the only way out of this. I really don't think so.
You don't think adopting
I'm asking whether that should be the only way out, or there are other things that one must do.
Okay, so it forms the basis of treatment of a lot of these non-communicable diseases and cardiovascular diseases. Lifestyle management is the basis, because if you consider the risk factors, so for cardiovascular diseases, you have hypertension, diabetes, high cholesterol, sedentary lifestyle, being obese, poor diet. Those are the risk factors. Those ones are modifiable. So you realize that with your lifestyle, you can change the bulk of the risk factors for cardiovascular diseases. The other ones you can't do anything about are your age, because increasing age is associated with it. If you are black, if you are male, or if you're a postmenopausal woman, those ones you can't do anything about. If your family has a history of getting strokes and heart attacks, you can't do anything about. But if you realize the list of modifiable ones is tall. So that's why we put a lot of emphasis on lifestyle, and there is treatment for the various risk factors. So hypertension, you have medications that you also take.
As I'm talking to you, the watch keeps telling me it is time for me to stand. So it tells you, how the kind of work we do, our daily activities also fuel some of these. And I'll bring in Anna shortly, but I just want a quick response to this. And those who are battling hypertension, BP, hypertension, and all those issues, those who are on drugs, the complaints that has always come up, Some say that when they take it, it reduces their potency. They'll become impotent. And the reason why most people stay away from taking the drugs, even though when they've been put on it for life.
Yes, that's a problem we have. A lot of our male patients who are diagnosed 30s, middle-aged patients, they don't want to take the antihypertensives. Yes, some antihypertensives have been associated with erectile dysfunction. It is well known. But hypertension itself, its complications, blocking of the vessels, can also result in erectile dysfunction. So if you take the medications and you have erectile dysfunction, what we expect you to do is report to the doctor that this is what I have noticed.
Is there a medication that can reverse it?
There are alternatives.
When you are on BP medication?
So there are alternatives we can use if you experience that side effect. Mind you, not everybody will experience that side effect. So if you come and you report it, there are alternatives. We can try that. If we are out of options, then we give you something to counteract that erectile dysfunction effect while still being on the medication to control your blood pressure. Because without the medication, you may still end up with erectile dysfunction, or you may end up with a stroke and you won't be able to use...
And you will die.
Yes, you could die and you will still not be able to use the organ in the first place. So.
Right. Now, I mean, let's look at the Ghanaian general approach to his or her health. I mean, 2 days ago, I hosted somebody here. She has throat cancer, so she's lost her voice. She went through surgery and they gave her this artificial, there's a tube that helped her to speak. And she said that she was having issues talking, and then she had swelling of the face. When she went to the hospital, she was diagnosed. But when she got to know of it, she had reached the fourth stage, or stage 4, which a lot of people, according to her, had died because they didn't report on time. And I'm guessing this sits in the overall Ghanaian appreciation to his or her own health states and how readily they are ready to understand what is going on in their body and take remedial measures to correct it if possible and to live a healthy lifestyle. From what you know so far, what you've done, the education and everything around it, is the Ghanaian really ready to understand his health state and take the necessary steps going forward?
Thank you. I'd like to start this question from the fact that if you're talking about Ghanaian, then we'll look at not just the people, but our policies as well. So, yes, we have different levels of prevention. You want to put in policies that help people make right choices. Then you also want to educate people so that they know and have that power in knowledge. Like you said earlier, for lack of knowledge, my people perish. So when you have knowledge, it gives you a certain power. Then the next level is the fact that you want to have a screening program or early detection. So the cancers that you talked about elsewhere, and even in Ghana, there are screening times, optimum times for screening for various non-communicable diseases. So for hypertension, ideally, anybody above 18,
you should be
checking your blood pressure when you come into our clinic. For your blood sugar, it's same, but like you said, these days we are seeing certain things a lot earlier. For cancers, depending on the type of cancer, some people may start in their 30s, some people may start in their 40s, some screenings will start later. And then you have those who have the condition and are presenting with some complication of the condition. So catching it at that stage when they are having symptoms or complications and trying to manage the condition, like what happened with your friend. She came in at stage 4, so it started and it's gotten to the end of the road.
Even when the signs were clear, she was taking antibiotics and all those, thinking that it was something else and not cancer.
Exactly. So I'm coming to that. So there are different levels of prevention. For we as a Ghanaian community, sometimes the decision to go to the hospital to see your healthcare provider is modulated by quite a few factors. One, money. We'll keep coming to the fact that people don't have money. So to pick a car to the clinic, payment at the clinic. I don't have money. So I'll look
some are
for
also not covered by the National
Yes,
Health Insurance.
Exactly. So I'll go to my local chemical shop, local pharmacy, buy a drug. And I'll keep buying that drug until I have some kind of very bad complication and I have to present to the clinic. Okay? At other times, it's about our belief systems that sometimes hold us back from going to the clinic. You know, in our homes, when you come up with a symptom, you have 1,001 doctors.
Everybody, you know, diagnosing you and giving you all manner of.
Exactly.
You know.
So then you are being told, okay, do this, do that. There's a local herb, there's this or there's that can treat it.
Not tested though.
For you, yes. And sometimes your friend's condition, I'm happy you spoke about that in particular. The number of ENT surgeons that we have in the country, I mean, I'm sure you can count them.
Right.
We don't have that many. Our workforce is not that large, and you would find most of them here in Accra. So if you are in a village somewhere, you only have the most basic clinical workforce. By the time you get to Accra,
the situation
is already far gone. So you are talking about issues with access, you are talking about issues with finance, you are talking about our belief systems. These are three major things that come into play when it comes to diagnosis of non-communicable.
So Chris, the advocacy you are embarking on, which direction is it taking?
Thank you so much. So it's multifaceted. One is to train persons living with NCDs to be their own voices. For us, we believe that the more people are brought into the fold to understand, first of all, what the issues are, and then how to also communicate the issues, and to the goal, which is to cause change within policy and also within our, our system in general, is one of my main things. I've been working with the NCD Alliance for the last 6 to 7 years, train people both in Ghana and people out of Ghana to be voices across the world. And so that is what we have done so far in the country. Also to speak to policymakers. We've had meetings with the Parliamentary Select Committee on Health, because if you look at what happened during COVID, where it was said that persons with underlying health conditions were at risk of contracting COVID-19, you have a lot of panic running through the NCD community, because for them, one little thing could trigger, a complication that could lead into a worse situation. And so for advocacy, it is ensuring that persons living with NCDs are well informed, are knowledgeable of the policies that even are in place, are also well aware of the lifestyle changes that they need to also adopt in order for them to be to have that life they want to live, even though they may be taking medications, and sometimes it leads into mental health complications as well, but to ensure that they are functioning as normal human beings within the society. But one of the things I also wanted to add to what Doctor said was, the decline in health promotion is one of the things that has kind of found its way into affecting that number we are seeing, 43%. You remember some 10, 15 years ago, we had just one campaign that talked about Akola Okohen, right? It was everywhere.
Right.
And it had this resounding effect in our lives growing up. And we knew what it meant. Though it was more of an animation, we knew what it meant. We embraced it, we loved it. And it had a positive effect on the youth within that particular, time frame, where they understood what the issue was, which was being communicated.
And you think that it's not being done now?
It's not being done now. It's not being done now. And what we are seeing most of the time is, for media, especially within the media space, sometimes I think it's a conflict of your sponsors, and then you putting some of these things out, and it looks like maybe you are biting the hands that are feeding you, but there is no intentionality with regards to health promotion. And that is one of the key problems that we see. I can go on.
Let me just ask now whether the health ministry doesn't have budget for for promotions. Is that really the case?
Health promotion is a major aspect of the Ministry of Health, the Ghana Health Service, the various aspects of the Ministry of Health. I believe what he's pointing to is that you can't point to any
sustained
advert
promotion
or
ongoing.
media promotion program that, like you said, Akalawo Kohe. As soon as you said, I was like,
you remember it.
Exactly.
We don't have that. And I believe that's what he's talking to. Not necessarily that there's no health promotion going on. Clinics, hospitals are doing health promotion every day, all the time. But that kind of catchy things that would help you to recall. There's something he said that is very important. Self-management.
Right.
Self-advocacy. I am a member of the group for which I'm here, the Create Ghana Research Group. We are funded by the NIHR, and we are involved in self-management education for persons with some cardiovascular conditions, as well as diabetes and other non-communicable diseases. Not all of them, but some of them. And a big part of that is self-management, empowering the client, empowering the person with the condition to be able to take their own decisions. Because to be honest, when you go to the hospital, how long are you in there with the doctor or whichever healthcare provider?
Few minutes.
Few minutes. Even if it's 30 minutes, it's still 30 minutes of a 24-hour day. When you leave, every choice you make after that is yours. So if the person is empowered to know and make the right choices, she talked about all the risk factors involved. Right. And the risk factors that she talked about, they are the same across. For most of them. In fact,
I will not cut you, but so this afternoon we're having the newsroom discussion about the throat cancer. And then we wanted to understand the risk factors. And then the issue of alcohol came, those who are drinking hard liquor. The issue of oral sex came. And you can imagine the debate that they brought about. So, I mean, people just run away from things that are so clear to them because of their own personal feelings here and there. But I just want to come to Florence and to ask. So, Chris kept using the word, if you are an NCD patient,
persons living with NCD.
Persons living with, is the tag good? Knowing very well how tags can be a tool for discrimination in this country. Is this somebody is living with HIV? Nobody want to get close to that person.
So I think that's the current approach. So you are living with the condition and you're not being defined by the condition. Okay. So that is why we call it persons living with an NCD. If you have HIV, it's persons living with HIV/AIDS and all those things. Because you're not defined by the condition. Because oftentimes we call you diabetic and you are defined by it for the rest of your life. And sometimes people look at you like you are incapacitated. You may miss out on opportunities just because of that label. But then if you know that it's just something you're living with, you'll be motivated to cope with it, find coping strategies, and maybe be more compliant with your treatment. And back to the issue about promotion, health promotion, I totally agree that we have really rested on our oars, and we used to do more with health promotion when we didn't even have the vehicles we have now. We have social media now. We have so many avenues we can do. Various health organizations and societies, like for the Ghanaian Society of Cardiology, we do some health promotion. Diabetes, DEMSOG does health promotion. So there are World Health Days marking various conditions. Then neurologists will mark stroke, cardiologists. Next month is May Measurement Month. We go around media agencies trying to raise awareness about hypertension, getting people to check their blood pressure, and even organizing screening for that. But yes, we need a national and concerted effort. Right. If we have a national health promotion project, they could send a message far, because we realize that sometimes all these efforts remain within the cities and they don't go far. Yeah, nurses used to, in the OPD, give education before you see the doctor. Now, that has all dwindled away. So we really need to revamp our health promotion.
Chris, want to come in?
You said something so significant. I just want to touch on that, about the tags that come with living with a condition. it is actually known in history that in the 80s, the HIV and AIDS community, when they adopted the person-centered approach, where the persons living with the condition were now the ones speaking, were now the ones, leading the conversation. It is what we are now seeing, the effects we are seeing today, that stigmatization and discrimination has drastically gone down when it comes to HIV.
And that was after they had realized that the initial awareness creation was wrong when they tagged people who were living with us, devilish and all those issues.
Exactly.
They had to revive the strategy.
Exactly. So now within the NCD community, we've developed that same approach. Recently, the WHO released the global, when we talk about meaningful involvement, putting persons living with the condition at the forefront of the discussion, making sure they are meaningfully involved. Like what Joy is doing right now, that I am also part of the conversation and not an afterthought. So that when it comes to discrimination, issues of stigmatization, we are fighting that every day, and it's still ongoing. You have people living with NCDs in some of the communities who people don't want to associate with because of, quote and unquote, maybe if I go close to this person, whatever condition they have, I may have the same. But we have adopted that same approach that was adopted in the 80s by the HIV and AIDS because they were successful. And that is what we also want to do now. We want to be successful. That's why you find somebody like me, you find other people within the NCD community leading the conversation. When we go for advocacy campaigns, you don't find a person without the condition
being part of it.
You find us leading.
And how has that helped in terms of the awareness creation?
It has drastically helped, especially in the trainings. When somebody can relate with you that you're a person living with a condition, then they want to listen to what you have to say. And most of the time, we understand what it means to live with a condition. Look, I've not used the NHIS in a very long time because I know how the disease burden increases. And when you go to the hospitals, you are basically paying out of pocket with regards to your medications, with regards to, your check-ins and all of that. And so we know what it means to live with a condition. We know what we had to even go through during COVID. And who best speak to the issue than us who live with a condition every day of our lives?
I think it's good, and I just want to come so that we can look at the way forward as we go. And personally, I appreciated my health very much. When in February, I woke up and walking was difficult because I was having so much pain from my right leg all the way down. And then when I went to the hospital, I was taken through a thing. There was a process and then MRI. And then the conclusion was that they call this sciatica. It's been very painful. And I've taken a lot of things for granted. But what that thing taught me, then I came to realize I should be periodic in terms of understanding my body and what it wants. So now going forward, what should be the approach, and what would be what are the takeaways that those who are watching us should take from this conversation in terms of their own health outlook?
Okay. So firstly, I believe from the beginning, we've not really defined non-communicable diseases for your audience.
I think we can do that now.
So non-communicable diseases, they are a group of diseases that, when we say communicable, it means that I can give it to you. So infectious diseases, so COVID, let's say HIV, TB, if I do something, I can give the condition to you. Even cough, cold, I can cough on you and the whole room will have a cold by next week or next 2 weeks. Okay, but non-communicable diseases are diseases that if I have it, I can't give it. You can't
transfer.
So then that brings us to what we've been discussing all this time. It's not something you can transfer. He talked about something that led me to this, that sometimes people will stigmatize you, sometimes because they don't understand it and think that they can pick it from you. So if you have hypertension and I may associate with you, or diabetes, or a cancer, or a neurological problem, if I associate with you in some way, somehow, I can also have it. The way forward, again, he touched on it, empowering the patient, empowering the person living with disease. Yes, we are the theory experts, so to speak, and they are the reality experts.
Yes.
Okay. Usually, managing a condition should be individualized and personalized. What you do for Amma is not what you would do for Kofi, because they don't have the same circumstances. But all people living with non-communicable diseases, one of the things that you want to look at is management of risk factors. The modifiable ones that Dr. Akunia spoke about. You know, the salt. We love salt. Kobe, tolo beef, and all the comininis. We love it. We put it in our food.
That's one they call salted beef.
Salted, yes, that's tolo beef. Sorry. Salted beef, salted pork, all the good things that we like to put in our meals. The oils, the palm oil that we drizzle on our food. So we are looking at our salt intake. We are looking at our choice of food. It doesn't necessarily mean you have to stop taking certain things. Again, it's individualized. But you must know what the food is doing to you when you eat it. So that when you are eating it, you know that this, I'm sure I can't say brand names, can I? So this flavoring that I'm adding to my food, this salted flavoring, that the spices that I'm adding to my food, now I know that it can affect my heart. It can make my hypertension more difficult to control. So it's tasty, but do I really want to take it?
So it is too much of it, isn't it?
Yes. Oh, it's not just some of them taking it at all.
It's zero.
Yes. Ideally, it should be zero. Again, it comes back to individualized. You look at all the risk factors and what the person you are looking at, patient-centered care, what their life is. Because if you tell somebody eat vegetables, the person can't afford vegetables. The person eats bangkun and raw pepper a day, and you are telling the person eats cabbage, eat this, eat that.
A friend of mine was on that, and then 2 days said he was having nightmares. And so she couldn't go ahead eating the vegetables.
However, there are options. Maybe they are thinking of lettuce, cucumber, this, that. But we eat okra, we eat kontomire, we eat garden eggs. We have our own local options. We drink light soup. So these are options that we can give. So depending on who is sitting in front of you, the education may be different. Okay, then you come to talk about smoking, alcohol, managing your weight, managing stress across day by plan. You talked about it. You know, you are so stressed all the time. You get home, you are stressed. Sleep is also something. So modifying these risk factors, empowering the person sitting in front of you, that patient-centered care, that person living with the condition, giving them a management plan that works for them, that they can maintain and sustain. That is the important thing. Remaining consistent will give them the outcomes and the results that allow them to live a full life.
Right. Yeah. Dr. Florence, the way forward.
So she's talked about risk factor control. I'm going to talk about health financing. We need to have a look at how health financing is in the country, whether we need to review the NHIS and see how we can best serve.
But it's about time.
The population.
And it only comes into the picture when there's a public outcry. Yeah. The last time there was those who have kidney issues, and all of a sudden there's a discussion as to whether the NHIS should take it.
So we need to really look into health finance. And then the Ghanaian must take responsibility for their health, and especially health finances. We know that the NHIS doesn't cover everything. Rarely do you find people putting funds aside for health. So if you do not put funds aside for health and you have an incident, then you're found wanting. You cannot afford it in the moment. It will take you years to either come to a diagnosis or even get intervention that you need. For instance, if you get a heart attack right now, and the main treatment is to open up the vessel for you, you need to have at least $3,500 and
$3,500
or the CD equivalent of that.
That's
right?
like 50,000 Ghana cedis.
Exactly. If you haven't saved, you do not have any form of health insurance that is going to cover for that. Yeah. You cannot afford this service.
You can't, unless you adopt the BIMA.
So what it says is that you won't get it. And if you don't get it, most likely you're going to develop complications like heart failure, shortening your lifespan, worsening the quality of your life. So those are the things we are looking at. Ghanaians must...
And so the review is very important.
The review is important.
The NHS is one of the biggest entities you'll find in the UK and the US as well.
Yes.
But in our case, there's even selectivity in the way the scheme applies in terms of the ailments that it covers. It's not wholesale.
Yes, it's not. So we need to review that, and we also need to prepare ourselves for that. And then we also need to decentralize healthcare. So I think the Ghana College is doing well, West African College. We're training a lot of specialists. So how do we decentralize, send them to the various regional hospitals, send them to the various district hospitals so that people can get access to them? Because someone doesn't want to come to Kolebu because I'll come and wait in the queue for 5 hours before I'm seen. So we need to find a way to decentralize and then make health more accessible to the patients.
Tomorrow is Saturday. I'm sure you will find a lot of people going up the mountains. So many of them. When they descend, what should they do?
When they descend,
when they go up and they descend, what?
Okay, so it's very good to go up the mountain and come down. When you descend and you have had your healthy meal and everything, try and make time during the week to go and see a doctor. Let them check you out. Let them see if you are even fit to climb that mountain, because you could climb and get to the summit of it and have a heart attack and die. So go and see your doctor, have a routine medical checkup, something you should do annually. Let them check your blood pressure, your blood glucose, your cholesterol, your weight, your height, tell you your BMI, and give you advice as to how to maintain or even improve your health. Then you can go ahead and do your walks and all the other things that you enjoy doing.
Chris, you have the final word.
Once again, I would want to say thank you for the opportunity. For me, health literacy, first of all, is important. Health literacy for all. Everybody needs to understand the increased burden of NCDs in the country. 43% is alarming. That is half of all deaths. We don't want to turn Ghana into a graveyard of NCD patients or persons living with NCDs, where that is all we see every day. Health literacy. Unfortunately, if you see the influx of new pro-NCD products in our market, it is no surprise that the youth are the ones that are at the receiving end of these. Now, you have all these e-cigarettes that are so attractive, and unfortunately, it's targeting most of the females, and you see them, and it looks fancy, but you are looking fancy, leading your way onto death, unfortunately. And so, health literacy is important, it's key. Government must also absorb NCD treatments, the cost of it. It's expensive. She mentioned an amount that you know that you can work 2, 3, 4, 5 years. You wouldn't arrive at that amount.
For somebody, it's a lifetime revenue.
Exactly. And so you are choosing between that and health that you are not too sure about you even make it out of. You understand? That is where we are, which is unfortunate. So for me, I think that we need to come together. We need to understand that, look, as a person living with NCD, it is a burden. Stigmatization, it's wrong. You understand? And we will continually fight this. Meaningful involvement is key also. I want to thank Joy Prime for putting me on this panel. This shouldn't be the end. You'd want to see...
But this is Joy News.
Joy News, thank you. You'd want to see a lot more persons living with NCDs leading the conversation so that people will understand what it means. You understand? I don't want anybody to sit in a wheelchair. I know what, in an inaccessible country as Ghana, the last thing I want is for somebody to sit in a wheelchair. You understand? Because it is difficult. I wasn't born like this. I used to run, live my life, play football. Who knows? Maybe I could have been one of the best Black Star players.
Yeah.
I am. Speaking on health, so you shouldn't get to this point before you realize you made wrong decisions, right? And so health literacy is important. Thank you so much.
I'd like to thank you so much for coming through this afternoon. And of course, Dr. Florence Koyo Akumia, cardiology fellow in training, Dr. Nana Akusia Kunadu, family physician, and of course, Christopher Abwenga, patient's advocate. We've been discussing non-communicable diseases, and of course, the discussion will go on. Hopefully, we'll bring them back to evaluate what we've done so far and whether or not it's making any impact out there. This